So you see a screen on, you see the patient, which is 38-year-old female presented with fracture D12, which was a burst fracture with incomplete neurology. But she wakes up with the paraplegia after the surgery, and this was the reason. It was a screw. So it was a misplaced screw. Similarly, you've had patients like when you were doing a degenerative lumbar canal stenosis, patient wakes up with the weakness in the leg after surgery, again because of the misplacement of the screw. Another case where you have again a misplacement of screw causing progressive weakness of both the lower limbs in a case of 54-year-old female with degenerative spondylolisthesis. Now, what went wrong in these cases was actually a screw. So basically, if you look at there are multiple studies which have been done like this, and I'm just quoting one of them, wherein they did a study on accuracy of pedicle screw insertion. It was a prospective CD study in 30 low back patients. Published in European Spine Journal, 152 screws were put by all senior spine surgeons, and they noticed there were 23% perforated or misplaced pedicle screws. But fortunately, only 1% had neurological injury. So we should not just learn how to insert pedicle screws. We need to learn how to insert pedicle screws in the pedicle and safely. So I'm going to speak only on the lumbar pedicle screws. The dorsal pedicle screws will be taken care, talked by Dr. Appaji. And so basically, if we talk about the indications, basically the indications are the instability when you're dealing with a fracture, or you are doing a tumor, you're doing infection, deformity, or listhesis, where you won't need to do instrumentation, and you need some stability with your instrumentation in the spine. And before we move further, we need to also know what's important to know is the anatomy and the anatomical relation of the pedicles, the thoracic, lumbar, and sacral vertebrae. We will be talking about the technique of putting the pedicle screw, starting from the patient positioning, exposing the spine for that, the pedicle screw insertion technique with the entry point, what should be the entry point, what should be the trajectory, and what should be done when you are in trouble, when you have already misplaced. We should talk about it in brief. So we all are aware of our pedicle anatomy, our vertebral anatomy. We have our vertebrae. I'm going to speak only from lumbar, from L1 to L5, and sacrum. I'm just going to brush on that. We all know the pedicle is a tubular bony structure which connects body to the posterior elements, and it has identical predefined trajectories which are taken by the screw itself. So you are supposed to be going through the pedicle, and you need to know your anatomy very well so as to place it safely. Anatomically, if we talk about the lumbar spine, the pedicle trajectory, we have to take care of two basic things. First, the entry point, and then you are supposed to be aware of what is the lateral medial convergence and what is the cephalocaudal angulation. So these two things, or three things in fact, would make your insertion of a pedicle screw in the lumbar spine very safe. So we're just going with that. If you look at this particular graph and we talk about the transverse angle, that is a convergence angle. The convergence angle is highest is at L5, and it gradually comes down at L1. Speaking only of the lumbar spine, if you look at the first half of the graph there. So the convergence is maximum with L5, reducing down to L1. So starts from 25 to 35 degrees in L5, and it goes down to 10 to 15 or maybe 20 degrees in L1. I'm talking about the transverse angle convergence angle. Similarly, if you look or talk about the chordocephalous angulation, again, it is maximum with L1 at more or less same in the lumbar spine, but it's maximum with L1 and reduces in L5. You can see the diagram what I mean by chordosuperior angulation. And if we talk about the pedicle width, again, the L5 pedicle is the widest of all, and it gradually the width of the pedicle reduces down to L1 if you look at the first half of the pedicle of this particular graph. So this would give you a general idea of the anatomy of the pedicle, which would help you in inserting your pedicles. If we talk about the anatomy, there are certain anatomical relations which are very important to know and visualize 3D when you are putting this in a patient. Mainly, you will have the dural sleeve, or you will have the cord or the nerve root when you're on the middle border of the pedicle. Inferiorly, you will have the foramen, which would be carrying a nerve root. Laterally, you will have visceral structures, which could be muscle. It could also be a vessel. And anteriorly, again, you will have vessels and thoracic duct in case of thoracic spine. Now, coming to technique, positioning is very important. You need to simulate the anatomic position. You have to maintain the lordosis when you are doing the lumbar spine. You need to keep the hip and the knee flexed, as seen in the diagram below, so that your pedicles, actually recreating the normal sagittal balance or normal lordosis for the patient. While positioning the patient, you need to be very careful of protecting the bony prominences and the eyes, and obviously you need to prevent hyperabduction of shoulders. When you expose, you have to mark your level and the incision very precisely using your C-arms. There are multiple ways of doing it. Some people do it with a metallic thing, or sometimes you insert a needle and then you take a C-arm picture. You confirm your level, which that's the first thing that you do, confirming your level. Then you dissect along the bone. So dissection is also a very important part of your insertion of your pedicle screws, because dissection, if the field is clean, if it is hemostatic field, nicely dissected out, it is good. So dissecting along the bones would reduce your blood in the field and would give you a good visualization. And dissection always is good when you're doing a dissection from quadrant to cephalad direction, because that is how the muscles are oriented. This is how you are supposed to be dissecting. The exposure should laterally expose the pars, facet joint, and the transverse process. So by saying that, if you see the red part, that's the pars intra-articularis that you need to expose before you insert your pedicle screw. Then you also need to expose some part of the superior facet and the transverse process. So all these three things should be perfectly visualized before you start putting your pedicle screws. Coming to the technique, the entry point, there are three techniques which have been, or three entry points which have been described by Roy Camely, by Weinstein and Magrel. The Roy Camely one is the most medial one, and when we talk about the Magrel, that's the most lateral one. So it depends upon how you have been trained and what you're going to choose. But most commonly that we choose, let me talk a little bit about the Roy Camely technique. It's the intersection of the mid-transverse process line and the mid-facet joint, mid-facet line. The Magrel technique is junction of the lateral edge of superior facet and the midline of the transverse process. And the Weinstein is the lateral and the inferior corner of the superior facet joint. So Roy Camely, the most medial, just lateral to it is the Magrel's, and just to go superior and lateral to it is the Weinstein technique. But usually the most commonly, which is used by all of us, is the simplified tangent technique, where you just connect the mid-transverse line and then take a lateral from the superior facet joint, and wherever they intersect, you take that as the entry point for the lumbar pedicle screws. Technique-wise, trajectory, lateral to medial, you have to look at your convergence based on what level you're doing, whether you're doing from L1 or whether you're doing L5, based on what angles are there. And then again, you have to take care of the lateral to medial, that's convergence, which is assisted by the spinous processes, which you see. And sometimes the lamina also guides you as to how much of medialization you have to do, or convergence you have to achieve when you're putting your probe inside the pedicle. Superior, inferior, again, there are two ways of assessing what you're doing it right or not. The most easiest is to take the assistance of the lateral x-rays, which guides you as to your superior, inferior trajectory. Or you can use or you can just go perpendicular to the facets. So that is one way of going subchondral. So you should ideally target your screws subchondraly, where the bone is good and the stock of the bone is good, so you get a good purchase there. So again, if you choose your medial entry point like Roy Camely, you will go a little straighter, and if you choose the most lateral one, then you can medialize your screw more. So again, you have to be very sure what technique you're using, and this will guide you as to how much convergence you can afford to do there. Again, trajectory, transverse angle convergence, as you see, it's more in the L5 and reduces down to L1. Cephalocaudal is again more or less same in the lumbar spine, which is obviously little less for L5 but more for L1. For the S1 screw, again, you start at inferior, just lateral to S1 facet joint, and you converge more because you just have a very good stock of bone there, and you can go for a bicortical or a tricortical purchase depending on where you exactly keep it in the subchondral bone. So the steps or the technique of putting the pedicle screw is, first step is you decorticate the entry point, whichever you choose, with the help of a burr or a nibbler. Then you prepare the path along the trajectory. That is done with the help of a probe. Now that probe is usually blunt that we use. There are two kinds of probe that you will see. One is a little curved, that is what is called as a Lenkes probe, and the other one is a straight probe. Either can be used based on your experience, based on your training. But for lumbar spine, I think a straight one is good enough. And but you need to understand that you are using a blunt probe. You should not force your entry or your trajectory in the pedicle. You are basically passing through the cancellous bone, so it should go easily. If you are experiencing any resistance during putting your probe, you need to rethink, reevaluate, reimagine the picture. You may be hitting on one of the walls, so be careful of that. So resistance is not something that should come in your way unless and until it's a sclerotic pedicle. Usually you will just sail through. And most important, you need to have a very good tactile feel. So feel when you are traveling, you just go a little bit down. You can again, do a sound and see for all the walls. You obviously always confirm your probing with the sound that is available, and you feel all the walls, that is a superior wall, inferior wall, medial wall, lateral wall, and the anterior wall. With the help of a Shyam also you can do it. You can use, there are multiple things now available with the PEDICLE navigation and EMGNC, which can be again used to put your screws most accurately. Now, tapping, repalpation, and screw placement, and then happens, and you put your screw there. So I'm just going to skip this thoracic spine trajectory because Dr. Appaji is going to take this. So yeah. So the problems can be a breach, a perforation, intraoperatively or postoperatively. The preclinical manifestation can be in the form of a leg pain, neurological worsening, deficit, implant failure, vessel or visceral damage. And radiological manifestation may not always be there. Most of the times, patient may just be asymptomatic in spite of a misplaced pedicle screw, but within the limits. So if you encounter a complication, whether and you're contemplating whether there is a revision is required or no revision is required, then if you have a neurological deficit, if you have leg pain or is a vessel injury, then there is no doubt that you will go and revisit the patient and you do the required thing. Screw salvage, you always create a new pathway, and this is what you do in a thoracic spine. But whereas in the lumbar spine, you can either use a longer screw or a thicker screw to salvage the previous screw. Sometimes the pedicles are so large, you can actually make two entry points or two trajectories in the same pedicle. But again, you need to be more careful when you are probing your pedicle in a different trajectory. So conclusion is safely placing pedicle screws is mandatory for adequate mechanical stability. And the carry home message is spinal instrumentation is demanding. Practice makes a man perfect. So please do practice initially. Take as many shoots as you want. And one day will come when you will not need Shyams actually. Follow the basic rules. Surgical anatomy is the crux to success, and safe instrumentation is possible. Aim for no error surgery. Thank you so much.